Great. Well, welcome everyone to our Dunlevie lecture series. People are still filtering in, but I thought we'd start with some center updates. Just a reminder regarding the fall 2024 seed grant cycle. The applications will close on Monday, October the 14th, just before midnight. And to remind everyone, the center funds 2 awards, $35,000 each for 12 months starting January 1st, 2025, and feel free to visit our website. We got great news regarding the 2025 SMFM conference. So great kudos to our researchers. 94% of our submissions were accepted, including 15 posters and 2 oral presentations, one from Dr. Igbinosa and one from Dr. Pinelli. This is, I think, the best showing we have ever had, and really a testament to everyone's great work. So congratulations. Our next speaker for November will be Yoav Yanon, who is head of the fetal medicine unit at Sheba Medical Center and part of the Sackler Faculty of Medicine at Tel Aviv University, and he will be talking about fetal neurologic injury and complicated monochorionic twins. But for our this month's esteemed speaker, I will turn things over to my colleague, Dr. Yair Blumenfeld, to make the introduction.
Thanks, Yasser, and thanks everyone for joining. I see that the cohort here is really well representative of the different disciplines that are involved in the care of these fetuses and neonates. So I'm really happy everybody was able to come together like this. Dr. Miller has presented in a different form previously, and so some of you might already be familiar with her. But for those who are not, Dr. Jena Miller is an associate professor at the Department of Obstetrics and Gynecology at the Johns Hopkins School of Medicine. She is really a preeminent MFM and fetal therapy expert and is the co-PI of the NIH renal anhydramnios fetal therapy trial, the RAF trial, which many of us on the call are a part of, and that's really how we got to meet Jena originally. Dr. Miller obtained her medical degree at the University of Miami, and then completed her MFM fellowship and fetal therapy training at the University of Maryland with Dr. Amit Bashat, who some of you might know, and then moved to Johns Hopkins, I want to say approximately 10 years ago now, and has been rising meteorically through the academic ranks of the Johns Hopkins system. Dr. Miller has over 130 peer-reviewed publications, numerous book chapters, letters, and is really a frequently invited lecturer and course director in our field. And she's currently the site PI as well as on the executive board of the North American Fetal Therapy Network. I want to just mention on a personal note, Gina, it's been a lot of fun for me to get to know you over the last couple of years and really collaborate with you. Really impressed with your leadership style, intellectual curiosity, and how collaborative you are. And I think many people on this call would attest to that. I think the patients that you take care of in the greater Baltimore area are truly lucky to have you there. I'll stop talking now, give you the Zoom stage, and I'll just reiterate what Yasser said. We're really, really excited and honored to have you join us today. So I'll let you take it.
Really, thank you. Yes, we should definitely have some time for questions. And really, thank you so much for the invitation. And I also echo that sentiment. Working with Yair and the team there has been like tremendous, and I just really appreciate all the thoughtfulness, the guidance, the input along the way. It makes this trial and everything that we do better with your advice always. So let me share my screen here to get started.
It's kind of in presenter mode, Gina.
Yep.
Okay, just want to make sure you know.
There we go. Is that correct?
Beautiful.
It requires all the clicks, depending on which which computer we're at. So, so today I'm going to talk about serial amnioinfusions for fetal renal failure, and specifically the renal anhydramnios fetal therapy trial. And for disclosures that are different from RAFT and renal agenesis, I do some additional work and research with Johnson & Johnson and BC Platforms. So it's topics completely unrelated to RAFT. But first of all, one thing that's unique about RAFT is it includes not only bilateral renal agenesis, but also a group of pregnancies that are affected by fetal renal failure. And as we know and we're familiar that renal agenesis is by far the most severe presentation of fetal renal disease. And just to put into context how frequent this happens and how important it is, and a condition that we're facing as an MFM community is essentially, it affects about 800 live births per year. And so that's about 2 to 3 newborns born per day in the US. And so this is not a small problem that our patients and families are dealing with. And what's so challenging about renal disease, and specifically renal agenesis, is that it's a double lethal disease. So anhydramnios all by itself is lethal due to the resulting pulmonary hyperplasia. And then secondarily, renal agenesis is lethal without renal replacement therapy. And so the natural history of this condition is therefore invariably lethal, as we're all familiar. Now, perhaps most people are familiar with this one particular case that generated a lot of interest in the lay community and the lay press back from 2016. And so there is a congresswoman who was treated, got serial amnioinfusions. This was a case report was published in the Green Journal. And so it definitely started a lot of enthusiasm for should we be doing amnioinfusions for renal agenesis, for severe kidney disease. And, this seems like a great idea, right? So here at Hopkins, we had to decide, well, with this little bit of information, how should we move forward, and how as a community should we address this? Because clearly it wasn't ready for prime time. These are single case reports that were around at the time. And so we really wrestled with here at Johns Hopkins how we were going to attack this problem moving forward. And this data is a little bit dated as well, but I think from an MFM perspective, we think, we can get over that first hump, but what does this mean really for the big picture, to the life of a child in long term? And around this time as well, there was some more information that was coming out about outcomes regarding pediatric dialysis and survival rates associated with from children who had end-stage renal disease from early in life when they were born. And so, this was some of the information, although it's dated, that helped us to see kind of the bigger picture that maybe this is a disease we should attack and should think about more seriously, and is worth the investment in these pregnancies to try and achieve that first important milestone. And so this data is from the North American Pediatric Renal Trials Collaborative, which includes patients who are enrolled once they are on outpatient dialysis. And the part that was really encouraging for us in our group is that the survival was actually reasonable, that these numbers were somewhat hopeful, and that transplant was the most common reason for some of these kids stopping. And so for that reason, it kind of pushed us into thinking about it from a bigger perspective, and that we should consider how we should treat this disease. But the first most important question that we didn't know is actually how successful are amnioinfusions to prevent that very first step of lethal pulmonary hyperplasia. And that's really the question of the RAFT trial. And so around that time, there was, as I alluded to, very limited data about that amnioinfusions may be helpful to avoid lethal pulmonary hyperplasia and perhaps early survival. Now, along that time, right around that time as well, there was a workshop with the MCHD and NIDUK to discuss this issue, and a research agenda was proposed. And then as a next step, we held an ethics summit with multiple specialties that would be involved in the care of these infants. So not only our MFM providers, our pediatricians, neonatologists, the nephrologists, the transplant doctors, but also ethicists, insurance representatives, and also to include the ethical considerations surrounding this potential intervention. And so all of these things really served as the basis for and contributed to the design of the RAFT trial. And additionally, so the RAFT trial as it is now is a multi-center trial, but I'll even step back a little bit because when we first started this, we were a bit on an island here in Johns Hopkins, and we started actually as a single center site. And so we began an external pilot in October of 2017. And that was designed in order to kind of test the proof of principle as well of how to do amnioinfusions, how should we think about offering this intervention. And the experience in that external pilot actually further informed the implementation of the feasibility portion of the multi-center trial. And so there were a few patients that were treated in that cohort. And the thing that was most helpful for us in that early experience was to think about what actually is a technical strategy to do amnioinfusions. Now we know that a single needle, ultrasound-guided needle procedure is safe. We know it's safe for women, we know it's safe for the pregnancy. And the goal of amnioinfusions is different, though. We're trying to maintain fluid for as long as possible over the whole duration of a pregnancy. And so we recognize that each intervention of an amnioinfusion has an independent procedure risk. And so initially our strategy was, we'll just do as few interventions as you can, stretching them out to minimize the number of procedures in order to achieve restored amniotic fluid, which is different from as we move more into feasibility, we're using smaller volumes, shorter intervals to try and minimize that fluctuation and keep things more stable over time. And so we have analyzed how actually should this procedure be most effective in order to achieve that goal. And so one thing that we learned is that more frequent, smaller amnioinfusions allow a longer latency period up until pre-prom without increased obstetrical complications. So this kind of that early experience that we had here at our single center site informed more of how we're approaching it as a big group now. And so I think that's kind of important to understand that transition of how we are today and for the intervention that's performed. And so the current renal anhydramnios fetal therapy trial and its multi-center design is non-randomized, open label, multi-center, and originally began with 9 fetal centers and performing serial percutaneous amnioinfusions really to improve initial survival. And there were RAFT had 2 parallel non-comparative intervention arms, one for bilateral renal agenesis, one for fetal renal failure, and which is really all of the other non-renal agenesis causes of fetal renal failure, and an expected management arm, which was not comparative, but planned to just confirm the disease's lethality without intervention. And the primary outcome is decided as neonatal survival to greater than or equal to 14 days and placement of dialysis access. And this is chosen as a surrogate in order to show that the absence of lethal pulmonary hyperplasia and the ability to just institute treatment for end-stage kidney disease in a neonate. And I'll share with you as time goes on where we are now with RAFT, but because I'll present to you kind of the data that's associated with the bilateral renal agenesis arm, it's important to know the context. And for the specific aims of this trial, the first one and the most important one is it's about safety and feasibility of this intervention for the maternal participant. So we need to understand what is the safety profile for this intervention. Also, our secondary aims are to understand the efficacy, how frequent could we get to starting dialysis, as well as how can we correlate between the radiologic findings that we see, any biomarkers and survival statistics. And really the third thing is about how effective is this long term. And so how frequently can we get kids going home from the hospital, survival to that final transplant, outcome, and then also to touch on quality of life. And so a lot of this work is still ongoing. And how an amnioinfusion procedure actually works and looks for those of you who might not be maternal fetal medicine physicians. So this first one is by far the most complicated one. It's done under local anesthesia with a 20 or 22 gauge needle and ultrasound guidance. We take that needle, find that potential space. So many times it's between the joint or in between the fingers or somewhere that you can identify that you can weasel your way into the amniotic cavity. We give a small amount of fluid in order to start to open up that space in order to generate that initial fluid pocket. Avoiding getting fluid in between the layers of the membranes is important. Being sure not to be subcutaneous with your needle and infusing fluid into the fetus as well is important. And then gradually, as we start to get more fluid, then we start to see that the fluid normalizing. And the babies always like to help. They become extremely active, and I'm sure you can attest to that. So they don't often keep it easy for us. And then for the cases that we consider for inclusion and exclusion in this trial, they are singleton gestations with a confirmed diagnosis and normal genetic testing. And so with renal agenesis, for the renal agenesis arm, it was only those without no kidneys or without any anomalies that were unrelated to the kidney disease. Normal genetic testing on either karyotype or microarray. Patients had to meet with all the multi-specialty teams that care for children with fetal renal disease and ultimately transplant. Amnioinfusions had to begin by 26 weeks. That initial delivery care and postnatal care had to be at a RAF site. And then prior to participation, they require a diagnostic amnioinfusion to complete the anatomic survey, to confirm the diagnosis, and exclude EPROM, which is important for this group of patients. And notable exclusions were any technical limitations to performing amnioinfusions, any severe maternal medical conditions or obstetric contraindications to the intervention. And importantly, most parents must participate in the consenting process and agree to study participation. And so enrolled participants underwent serial amnioinfusions between 1 and 3 times weekly after their enrollment to maintain fluid for as long as possible. They had a delivery at a RAF site, and survival outcomes were reported at days 15, 30, and 90, as well as at hospital discharge. For those children that were on outpatient dialysis, they're enrolled in the Naprotics database as well, and the final outcome measure is transplantation. And one thing I'd like to just highlight that wasn't part of the criteria of the required consults is, in addition, that palliative care consultation was not prescriptive or required, because we certainly know that this pathway can go a number of different ways. That for us at Hopkins is kind of built into our immunology consultation, but something as we think about moving forward of what might benefit patients who think about this intervention. And so what I'll share with you is have the results of the published arm of the RAF trial. And so in 2022, we did have some observations of mortality and morbidity among some of the infants surviving past our short-term outcome. And so an interim analysis was performed after about half of the accrual of our sample size and presented to our DSMB. After that data was presented, they recommended pausing that arm of the trial. And so we ultimately decided to close the arm among our investigator group and report the information thus far. And so at the time of the data lock for this analysis, there were 321 individuals who were assessed for eligibility. 122 of them came to a screening visit at a RAF site, and 85 were excluded. Most common causes for anomalies, decision for termination of pregnancy, or other contraindications. And of those that were enrolled, a total of 18 were assigned to the renal genesis arm. Still, our renal failure arm is ongoing, and so is our expected management arm. And so the study population of this arm is predominantly white and non-Hispanic. The median gestational age at the time of the first amnioinfusion was 22 weeks, and delivery on average was at 32 plus 4 weeks. Live birth rate was 94%, with one fetal demise that happened after PPROM at 24 weeks. For our primary outcome, among the 17 pregnancies with live birth, 82% survived to that first milestone of 14 days in placement of dialysis access. And then to orient you to the rest of the results section, the overall population is in teal with those circle highlights. Survivors are in dark blue and non-survivors are in gray. So obstetric complications encountered were most common bleeding, with or without evidence of placental abruption. Chorion amnion separation was also pretty common at 28%, and ultimately 61% experienced PPROM, or pre-labor rupture of membranes. For survivors, there was a longer interval from the first infusion until PPROM, which makes sense that we just had a longer duration of maintaining amniotic fluid compared to our non-survivors. And there were no major maternal safety concerns that were identified. When we look at factors associated with survival to that primary outcome, they had a higher number of total amnioinfusions, and they were born later. So survivors were born at an average of 33 weeks versus 30, and all of our survivors were born after 32 weeks or later gestational age, and accordingly had a higher birth rate. But beyond the primary outcome, that time hospitalization is long, and ultimately there were mortalities during this time period. And so 6 of the infants, or 43% of those who met the primary outcome, were ultimately discharged home. And this just shows you the number of hospital days for each of those individuals until their time for discharge. And then there were 2 additional mortalities after discharge home, leaving 24% of the COBRA arm is living. And as far as I understand, that is still a durable number. This now I'm just going to show you, because one of the things of interest has been, well, what happens to these neonates after they're born, and what is their cause of demise? And so in this table, I'll share with you what the cause of death in these that were live born. And so the vertical axis is the time of birth. On the x-axis is time. So to the left is during the pregnancy or gestational age, increasing from right to left, and to the right is age and use from left to right. And each bar is one individual child. So those in yellow are the ones who died before the primary outcome, and those in black died after the primary outcome. And these are from the clinical records are the reasons associated that we could pull out of what were the contributors to death at that time. And so what was notable is initially we had issues with respiratory failures, pulmonary hemorrhage, also sepsis. But as time went on, when we look at what are the common themes, really sepsis was one of the biggest contributors to mortality among this cohort. And another complication that was prominent and observed in this cohort is strokes. And so we recognize that in several infants, and also 2 of the 4 surviving infants. And what's interesting is there is no particular pattern of timing distribution for these events, and we don't always have an etiology for these stroke outcomes. And so one of our big questions is really, how does this intervention and what does this mean for long-term neurodevelopment? And so ultimately, the COBRA arm of the RAFT trial was suspended by the DSMB in 2022, citing that we achieved that primary outcome in a high proportion of patients, but we can't ignore the burden of morbidity and mortality. So that is extremely high. And so we've been continued to think about that and to look toward what else we need to learn from this population. And there's no question that children without kidneys have a lot of risk factors for stroke, right? They have no kidneys, they have endothelial dysfunction. These babies have hemodynamic instability when they're born, and a lot of other concerning things that predispose them to stroke. But what's also challenging is we don't really have good comparative data to understand what we should expect in this type of critically ill newborn. And so, especially in a group that also might require replacement therapy. So understanding what is our anticipated background rate has been one of the unanswered questions to know how to interpret these findings. Now, Dr. Lammert, who is one of our pediatric neurologists, she has taken a really strong interest in the stroke pattern of these children and has done some of the initial preliminary work to try to understand this better. And so essentially what her observations show us is that from looking at the imaging for the cases that we've had, that some of these strokes do span multiple vascular territories. So we don't see any signs of aberrant circulation on fetal imaging or MRA. And the distribution can be on multiple quadrants and isn't always clear. And so, what's important is from the clinical records, seizures seem to be the most common presenting clinical symptom, and not always with an exciting clinical event of a change in the status of the newborn. And so ultimately, there's still a lot more work to do, and she at least published the initial series of some of our babies here, just to put out in the literature what are we seeing, what are we observing, to answer, so we can begin answering these questions to understand this better. Where we are right now with RAFT is recognizing that with our 9 centers, we still have one arm ongoing. We are trying to understand with the other arm, are outcomes the same? Are they different? Are they better for children who have some kidneys, even if they have fetal renal failure? So we've expanded our sites to complete our enrollment. And so we added 4 additional sites, and now we're a total of 13 to help to try and cover a better geographic distribution to decrease barriers of access to the trial. And where we are now, as of just the other day, we've pre-screened 485 patients. We have seen 179 patients on site, and 50 have been enrolled. 32 within our fetal renal failure arm, so we have 3 more to go to complete enrollment of this trial, and our renal agenesis arm is the same, of course, at 18. We have had several transplant milestones, and so we're continuing to collect that information, and several are listed for transplant as well. And so even though one arm is closed, the ongoing data collection will continue for quite some time. And certainly just the beginning, the publishing of this arm has generated a lot of interest in the news, a lot of discussion in our community about how do we proceed from here, because it's certainly a challenge of we have some additional information about how effective this intervention might be, at least in the short term, but still we have a lot of long-term questions to answer, and how do we navigate this? And that's what we've been really focused on as an investigator group as well. And one thing that at least we observe and feel is that the community engagement is really quite strong, and the demand for this intervention is ongoing. And so even though there may be some concerns of the long-term morbidity, mortality, and still a lot of unanswered questions, the interest is there. And so even this is just one example of one of our former patients runs a biomedical engineering company, and they're working on new PD catheters to help deal with some of the morbidities they're facing these children as well. And so it's coming from all angles that there's a lot of commitment to move this forward. And so we're enthusiastic about that as well. And but how to navigate that, as I alluded to, has been a challenge, and we've been trying to figure out the best way forward from many perspectives. And with Dr. Blumenfeld has been a major lead on this initiative as well. And so figuring out what do we do in this space from where we have some experimental therapy from our clinical trial, but we accept that this is not in the space of standard of care either. And so balancing that risk benefit for our individual patients, delivering this type of intervention in the appropriate setting with the appropriate resources, and being sure that we're giving informed consent to the best of our ability, but also maintaining the rigor of ongoing data collection and oversight. So where we're landing is that we're in this space more of innovative therapy to really still understand the long-term implications of this intervention. And so that leads us to where we are now, in thinking about the future and still some of the ongoing work that is happening. And so I'll highlight, and this is kind of the big picture overall of where we are, and I'll touch on where we're going next and continuing this work. And so for the quality of life data that I mentioned, so in RAV, quality of life data is collected every 6 months after patients are discharged home from the hospital. And so when it gives us, though, a big blind spot, right, between the time when the patients deliver to the time when they actually are discharged and get home from the hospital. And so the attrition also of the patients who aren't discharged home, we're missing within RAF the information about how this impacts our families. And that's been a really pressing question, I think, from our trial group and also DSMB and outside as well. And so not only are we continuing to work on the quality of life data, and I'll share with you some of the information that we have so far, but we also are working on a qualitative study for all of our trial participants, regardless of that. And so it will be a structured interview. It is undergoing evaluation by the IRB, and so we'll be reaching out, of course, to all of our sites about participation with that. And essentially, it allows us to try and understand for all of our parents, no matter what the outcome was, no matter which arm, how this really impacted them and their quality of life. As far as our management guideline, that some of that information has our neonatologist did a survey across all RAP centers to really identify where are some domains that we can harmonize our management moving forward and optimizing that. And I'll touch a bit on the work towards our multi-center registry and thinking about what RAF2 is going to look like. Our biggest questions are what are the long-term outcomes? And so RAF2 is undergoing consultation with our trial innovation network and is developing likely as a prospective cohort study, really focusing on the development. And so, as I mentioned, with quality of life, this is an example of a survey that goes out to our parents once they're home every 6 months. And so it hits all of these different domains that are listed here, talking about, how has this affected them for daily living, emotionally, relationships, and social functioning. And, our early results show that, this is a toll on our parents. It's 75% of them report that, things take more time, they take more effort, and not everybody understands their situation. 100% report that they often or sometimes or almost always worry about their child's future and the side effects of their treatment. And 87% of them often feel sometimes or always feeling anxious. And so, although we try to prepare our patients as much as we can, there's nothing living. And so it underscores what an impact this has on the families. From our management guideline development, from that neonatal survey, where there seem to be three main areas of how of where we can kind of target what might make sense to developing consensus guidelines. And so in whether that's timing, frequency of imaging, knowing that these kids are at risk for stroke, managing their hemodynamics, as well as monitoring of them and treatment of pulmonary hypertension and sedation, based on kind of how the treatment and the management is happening at our different sites, these seem to be the areas that make the most sense to start with. And then, the areas for further exploration, they felt that the nutrition management, the approach to renal replacement therapy, perhaps for the future in the use of additional medications, and some units are actually offering ECMO if it seems that the pulmonary disease is acute and recoverable. But there are still some areas where best practice at an individual institution seems to make more sense. And so that may be the initial respiratory management, also their renal replacement therapy initial mode, what requirements for each of those modes may be, and antibiotics or across sites. Additionally, we know that karyotype in a microarray may not be the answer completely to what that this diagnosis can be much more complicated. And so even within our own cohort, that when we do deeper testing, particularly with something like exome, we're often getting ahead of these. And so whether in the future for RAF2, should we think about all of these patients, and should they have advanced molecular genetic testing prior to enrollment, and would that actually help us target patients who might have a better prognosis? And so moving forward in this interim, because certainly we're hoping to finish the recruitment for RAF1, and then RAF2 is still something under development, and we will have this time delay. And so in this space of innovative therapy, our approach is with a prospective registry design. Now, it will have the opportunity to include retrospective cases, but for our prospective design, it really is designed to allow us to continue collecting our observational data for patients that are treated beyond the RAF trial and before a second clinical trial. And so this would be open to not only our current RAF sites, but other intervention centers that are interested in offering this intervention. It would just document what screening procedures were performed. So similarly, we list all of the things that we do now for RAF inclusion and enrollment, and it allows each investigator or person entering that data just to check what was done so that we can assess that moving forward. For those who consent for ongoing data collection, there would be a consent form, and then they would undergo their serial amnioinfusions. There is also the mechanism to enter data for those that receive an amnio report beyond, and because some sites are offering that as an alternative, or just the percutaneous amnioinfusions. The information is collected at the time of delivery, as well as a few mirror data points from that 15-day time point as well, just so that we have that same point to compare to our clinical trial, as well as at hospital discharge. And again, the final measure is transplantation or up to 4 years of age. And so the data collection for this is designed really to be at that delivery time point, hospital discharge, and the final measure to ease and hopefully improve the capture rate for that data. For any retrospective cases that are treated along the way or prior or in a similar time period for the RAF clinical trial, if patients had been consented for recontact, they can be consented to be included in the registry, or if not, then a waiver of consent and a limited data set can be contributed. Similarly, it would ask what screening procedures were performed, what consults were performed, were there genetics, how many amnioinfusions they had, what that gestational age was, any complications that happened along the way, and similarly, if that information is available at discharge and transplant. So overall, although we still have a lot to do, I do want to just kind of pause and give a moment of gratitude for our families, that although we focus really on the success, the measure of those that are survivors, those that are getting to transplant, we certainly know that a lot of our families just do not have that same outcome. And we can't negate the fact that their participation in this trial is important too, and what their feelings are. And so what's interesting is, and we really appreciate kind of this one measure, or this note that I got from one of our trial participants, who said, we prayed for a miracle and we got one. It wasn't the one we hoped for, but we're so thankful for the days we got to love on our baby, the quality of time we got to spend with him, and his contribution to modern medicine. make our participation in this trial priceless. And so we don't want to miss the importance of their experience in this as well. So finally, I just want to acknowledge all of our teams. It takes a whole group to run a trial, particularly the NIH, the North American Fetal Therapy Network, all of our center PIs, coordinators, staff, the nephrologists, all our pediatric teams, and by all means, I do want to acknowledge Dr. Eric Jellin, who was our original PI and really the heart and soul of this trial to begin with. And so I'm sure we have plenty of time for any additional questions and discussion. Thank you.
Thank you so much, Jena. Maybe we can unshare. Great. I think a lot of different services are on this call now, which is great. A lot of people who personally participated in the study or have an interest in the study. Everybody from our regulatory folks to Stephanie Leonard, who's on the DSMB. By the way, we do have a Chinese wall across our offices for full disclosure. And a lot of our neonatology and pediatric colleague, pediatric nephrology. I want to open it up to people who probably we all have a lot of questions, but maybe people who don't normally communicate with Jena, maybe offering them an opportunity to ask a question related to either neonatal or nephrology care, or just to make a comment about your respective fields and how you see this trial, sort of reconciling this trial with advances in your respective fields, I think is really an interesting aspect of being a part of this trial.
For sure.
Anybody wants to make a comment or ask a question?
Jena, I have a question relating to the prospective registry. How many sites are actually enrolling renal agenesis right now?
No sites that are part of RAFT that I know of are performing this intervention for renal agenesis. None that I know of, but there are sites outside of RAFT that are performing amnioinfusions, some for renal agenesis, and there are several sites that do amnioinfusions for patients that were also declined from the RAFT trial. So that's still ongoing.
And the registry that you're talking about would not include those patients, correct?
It would be open to those patients.
It would be open.
Right now, this is, it's a real missed opportunity that we know that's why the ability to include retrospective cases is also open, so that for those that are open, that we can have the opportunity to capture as much information about this intervention for as many patients as possible. So we're hopeful that that we'll have buy-in from many centers beyond that.
Yeah, to clarify, the registry hasn't started yet, right. And is going to be launching. Actually, this group is getting a preview of next week's NAFNet meeting, where Jena is going to present this to the entire NAFNet organization. So we're getting a sneak peek on that. But the idea is obviously to allow additional data collection, to allow us to enroll these types of patients under an IRB scientific umbrella, because clearly there's been a moratorium amongst the NAFNet centers for sure, and the RAFT centers on doing amnioinfusions for bilateral renal agenesis. And so this is sort of a way of allowing us to do that in a scientifically rigorous manner.
Yeah, this was a fantastic presentation. Thank you, Gene.
Any comments from neonatology or pediatric nephrology and any advances that are coming related to this in your neck of the woods in the care of these labile and precious neonates? I'd love to hear from you. Okay.
We have comment in the chat. From Danielle, thank you and congrats on getting all this done.
And I do have to say, from our neonatology work group, their insight and their commitment to really thinking about how to take care of these patients best it has been really so appreciated. because they've been so thoughtful about meticulous care of these neonates, and they're just such an engaged group, and it has come into it, including the nephrologists and everybody else. I mean, there's so many people that are thinking about how to optimize the outcomes from every angle, and that's been really really rewarding overall, because there's no question this trial and every part about it is difficult for everyone.
Alexis, jump in, please. No need to raise your hands.
Oh, okay. Yeah. Can you hear me?
Yes.
Okay. So, you know, I'm so appreciative of this trial, because from the families who've been involved, it's really given their families and their family goal and aspirations a chance that they never otherwise would have had. I think one thing that I find a little challenging is that, you know, these early outcomes, I think, very much reflect a learning curve with a pathophysiology that we had not previously dealt with. And I think I see Mary on the call, and I feel like we have rapidly evolved our approach to how we care for these babies. And I think in doing so, and I'm hoping at some point the data will support my thinking, is that I think we're getting better in terms of our outcomes. So I'm really looking forward to RAF 2.0, where you know, we can prospectively evaluate these babies and demonstrate that the intervention is worth the outcomes. So that's the first thing. And then the second thing is, I think among my neonatology colleagues, you know, when we think about the outcomes and how they were evaluated by the DSMB, you know, the survival rate is really actually even better than what we would see for babies born at 22 weeks. You know, babies born at 22 weeks have about a 30% survival rate. And among survivors, about a 50% chance of moderate to severe neurodevelopmental impairment. And so I dare say that it's possible the outcomes of these RAF babies are better than the population for which there is growing enthusiasm for offering a trial of intensive care. So I just wanted to kind of put that out there for perspective.
Well, and I think one thing that accelerated the neonatal care is we really, you know, the primary question of RAFT was overcoming an immediate pulmonary hypoplasia. So the confidence intervals and what our sample size and our population was based on was, you know, anticipating, are we going to get a 30% survival rate? Are we going to get that's what we estimated. And so we actually have more babies in this novel cohort than we were even anticipating from RAF 1. And so, and somewhat that reflects, that anticipation is reflected on how the trial design as well. So, you know, recognizing that we have so much more to understand about the neonates and the children that are becoming our intermediate term survivors and longer term survivors. It just highlights the importance of moving to the next phase beyond the initial question of RAF.
All right, thanks, Jena. Really appreciate taking the time from your very busy schedule at Hopkins to join us, and educate us, and hopefully this is one more among many future presentations by you and your colleagues. And I just want to thank everyone for joining from all these awesome disciplines, and really a testament, I think, to our institution, our respective divisions, that everybody coalesced so seamlessly around this project and in an ongoing fashion. So thank you all, and enjoy the rest of your day.
Thank you.
Thank you.